Good afternoon for everybody, and thank you very much for this possibility to speak with you. In this afternoon, we will speak about awake craniotomy protocol from brain gliomas. This is an experience from Spain in the Ciudad Real, in the university hospital. We know that in many cases, when the patient had some problems with some lesions in the brain tissue, the first question that we are doing is what we will do with these kinds of lesions. If the lesion is located near of eloquent areas, such as speech, language, or visual centers, or in a motor or sensory areas. What will they do in these cases? What is the risk of the permanent deficits in the language, speech, motor, and sensory function in these cases? Maybe if we see some kinds of these lesions, we can wait and see until the tumor causes some neurological deficits. Or maybe we can do in a biopsy, then after radiotherapy or chemotherapy. Or we can think about the surgical treatment. If we decide a surgical treatment, what kind of options we can choose? We can do it under general anesthesia, or we can select an awake surgery. If we do it in a awake surgery, we can decide if in one or more sessions. So on an awake craniotomy, in an ancient times, was used for trepanation to treat seizures and remove a variety of pathological conditions. There are a very described history of these kinds of surgery in the described by Jules history of awake craniotomy for brain tumor and spread in the Asia. So on awake craniotomy is another techniques, Renaissance maybe. In the modern era, they are described very well for Penfield, who used the pill in the epilepsy treatment. Thereafter, Penfield and Pasquet write on a surgical and anesthetics aspects of these kinds of surgery. And awake craniotomy is going on due to improvements in anesthesia techniques. The development observed in the neuroimaging techniques and the development of neuromonitoring techniques. So before they speak about awake craniotomy, we can ask about how many people are studied so much harder in the knowledge of the functionality of the different brain areas. One of this is the French neurologist, Paul Broca, who described anomia in one kind of lesions in the brain structures. Thereafter, in the modern area, so many investigators, so many doctors studied very well the different brain tissues, brain areas, such as drawings by Evelyn Royland, who is studied about their defects and their impairment after occupant lesions in the brain area. And awake craniotomy was the first discretion in the intraoperative applications of direct electric current into the human cortex was do it for Robert Bartholow in 1874. So many years passed between they are describing the modern methods and principles were pioneered in the 20th century by Krauss, who described the map of human motor cortex. Thereafter was developed by Kirschen, Forrester, and Penfield. Penfield and Ulgeman as working very well in epilepsy surgery. Roylen, Eveling, Schmidt, Eisner, we describe it firstly in oncological surgery. Berger was the first who applied the direct electrical stimulation method for mapping eloquent cortical areas for oncological neurosurgical purpose, who are describing the localization of cortical and subcortical motor and sensory pathways. Thereafter, Dufault extended and codified the indication of a direct electrical stimulation of cortical and subcortical areas. In the next decades, this technique has spread all over the world. The awake craniotomy protocol was used before in epilepsy surgery, such as was said, oncological surgery, in deep brain stimulation, and in other kinds of surgical procedures. The main indication for the awake craniotomy is to operate near of eloquent brain areas on different procedures, such as testing the treatment modalities such as deep brain stimulation, peripheral nerve stimulation, motor cortex stimulation. And the other thing is that the people who are passed under awake craniotomy have a shorter hospital day. The principal or the main objectives of the awake craniotomy is the assessment and identification of the functional neurological outcome of the patients with lesions in eloquent brain areas. We can do it a pre- and postoperative assessment of language function in patients whom surgical resection includes or is close to language areas. We can detect and assess the patients at risk of post-op aphasia, and we can reduce to the minimum the functional impairments after 6 weeks of post-op. To awake craniotomy requires one team with an experienced neurosurgeon, anesthesiologist, shape neuroanesthesia, neuropsychologist, neurophysiologist, and a very good surgical nursing team. But the first and the major requirement is the patient who can cooperate, who can training for this cooperation with a hemodynamic and stability, secure airway, patient and alert. We can very observe about the environment, giving to the patient a comfortable lying position and a temperature, and to look about the noise. The main is the excellent communication with the patient. In the intraoperative monitoring, we can have a routine monitoring such as blood pressure, pulse oximeter, blood pressure monitoring, Vis monitor, control of diuresis. But the most important is to ensure the patient comfort. About the anesthesia techniques, you can use local anesthesia, escape blockade, ensure an adequate sedation and analgesia. But more, again, it's very important to maintain a communication with the patient and ensure their comfort. This in the pictures, you can see the sites where you can do it, the trunk blockades and scalp blockades. You can use for the local anesthesia short and long acting agents with or without epinephrine. We can see about which one has what kind of cardiac toxicity, the scissors provocation. We can know about the propofol decrease the potential of the scissors. In our institution, we always use lidocaine and bupivacaine combined. The objective of the intraoperative neuromonitoring is to help provide basic, advanced, and fast monitoring of certain neurological functions at risk during surgical procedures. We can know the change in neurophysiological responses should alert the surgical team to make adjustments during the procedure. We need, I said before, a neurosurgeon with experience who believes in neurophysiological monitoring, who understands and knows limitations of the neuromonitoring, who know the correct monitoring of each surgical type, who understand the cause of technical changes, and ready to act appropriately in the time. We need one anesthesiologist who will be familiar with your neurophysiological monitoring, be knowledgeable of anesthetic effects on neuropsychophysiological parameters, be willing to adjust anesthetic techniques to accommodate the responses, be able to identify physiological and treat the different pharmacological changes, who provide support the blood pressure during surgical change. It's important. An anesthesiologist who check the position and possible nerve compression, check and increase the blood pressure, the anesthetic agents that can convert to a total activa, optimize the hemoglobin, use a muscle fluorescence as showed for the case, who optimize the temperature of the patient. The neurophysiologist who know the interpretive neurophysiological experience, knowledge of the type of surgery and kinds of anesthesia, ability to differentiate and find solutions to surgical, technical, physiological, and pharmacological changes, to have an important, good communications with the surgical team. We need a neuropsychologist who is familiar with our conditions, who have a good technical knowledge of a neuropsychological test in pre and intraoperative conditions, and important, who have a good communication skills with the patient and surgical team. We can use an electrical stimulation, and we know about an excitatory phenomenon and inhibitory phenomenon. There is an excitatory phenomenon as a sensory motor cortex and visual cortex and auditive cortex, and an inhibitory phenomenon such as language, memory, and higher cognitive functions. In this picture, you can see how we can do it, the speech area stimulation or speech area mapping. One can do it to the stimulus in the first time. We given a visual stimulation for the patient, and we can analyze the response given for the patients during this stimulation. In these pictures, you can see the cortical and subcortical stimulation. You are knowing the inversion phase of the central sulcus. In the second pictures, you can see the motor area stimulation, such as in the abductor stimulation or the abductor area. On a cortical map, key points as we need this as a good standard. It's a real predictor of functional outcome. This procedure is used to map in the brain and applying the current directly to the cerebral cortex by inducing temporary and localized activation of the disruption. The cortical mapping varies according to the studies and the institutions. The cortical mapping, we can do it under general anesthesia by motor evoked potentials and somatosensory evoked potentials. And in awake craniotomy, with a stimulation from one area of the cerebral cortex, we can have responses, verbal, movement, emotions, and sensations during these procedures. The speech testing is doing to identification of the broadcast area by induced speech arrest, identification of other cortical language areas by reading and words compression, such as in Wernicke areas, by data presented to or performed by the patient. And a polyglot patient may be a great challenge. The language areas may be a multiple within the craniotomy. The distribution beyond the area of Broca and Wernicke, it's very different. What is about the mosaic distribution? Approximately says 1 to 1 centimeter, and 50% of cases are separated. They can be in a parietal, lobar, and frontal cortex. You can help these kinds of evaluation preoperatively by PET or functional MRI. For patients with to awake craniotomy protocol, the inclusion criteria are tumors adjacent to eloquent areas, example, left peninsular tumors, tumors in pericentral gyrus, but they can be monitored under regional anesthesia as well. Recurrent or untreated lesions near or within the supposed language areas, Broca or Wernicke. The age between 15 and 70 years, be fluent in Spanish or other language, but spoken under compression. Mentally oriented.
Okay.
No severe aphasia before surgery. The exclusion criteria, absolutely sleep apnea, obstructive, claustrophobia, dementia of patient, and relative contraindications or exclusion criteria are epilepsy, refractory to drug treatment, airways of difficult access. The complications may be seizure, conversion to general anesthesia, respiratory depression, airway obstruction, oxygen saturation decrease, arterial hypertension, nausea and vomiting, and other things. But very important is the complications related to the patients, such as a need or sensation to urine, feeling cold, dry lips, itching of the nose. The imaging needed for this kind of surgery is as an MRI compatible with neuronavigation, MPH axial slice of 0.8 millimeter thickness. This study can be fused with DTI and or fMRI. In the neurolinguistic evaluations, we can use a formal neurolinguistic test, such as an Ashner aphasia test. This consists of 5 subtests: handling test, repetition test, writing language test, visual naming test, and underlying test. In our neurolinguistic evaluations, we can subset errors will be classified as known, minimal, discrete, moderate, or severe according to the rules of Ashner aphasia test. Preoperative patients information training, and at least 3 days before surgery, patients should be informed in detail about the process of intraoperative monitoring. The patient should be familiar with the material used for the stimulation and trained to perform the test. Operative management overall assessment establish a good relationship with the patient, inform the patient about all stages of surgery, and others such as control of drugs, special anticonvulsants, or patients may be a great challenge for these kinds of surgery. The patient position is very important to increase the comfort of patients, to reduce the intraoperative stress and anxiety, to allow the correct visualization of presented stimuli, and comply with the requirements of the surgeon. As said before, anesthesia techniques, and we can observe about pre-medications. What's about the basic monitoring? We need doing a bleeder catheterization. We can decide if we are doing a totally wake craniotomy, just with local anesthesia, or we can do it on a wake sleep craniotomy. In this picture, you can see the areas that will be blocked, the trunks or nerve trunks or the scalp blockade. For the electrical neurostimulation, we have 2 possibilities, such as a monopolar stimulation or bipolar stimulation. The monopolar stimulation pyramid stimulates trying to 5-7 with another stimulation, intensity of 2 to 16 milliamperes, frequency of 250 hertz, pulse duration 0.2 to 1 millisecond. The advantage of monopolar stimulation are mainly the risk of crisis is very low, 1.8%. Also, you can get with an AMG response, so you can measure the amplitude and latency of response and compare the previous care. The disadvantage is mainly the less focal stimulation than with bipolar. And with this type of stimulation, we cannot perform language mapping. The bipolar stimulation or bipolar mapping, we are doing with an interelectrode distance of 5 millimeters. Stimulations involve times of 5 milliseconds, 2 milliamperes, and with a frequency of 50 to 60 hertz. The stimulation intensity angle gradually increasing to a maximum of 16 milliampere. In the literature, they are seeing that we can extend under 20 milliamperes. If a post-discharge intensity appears to be of a 2 millimeter below the post-discharge, and mapping should be performed at this intensity. The post-discharge threshold observed in a boring region should not limit the intensity of stimulation. After stimulating cerebral cortex, the patient must be observed to view movement. In the language area, deficit should be assessed after it has achieved a carefully baseline, such as after performing a test of visual naming objects displayed for more than 1 minute and at 5 seconds intervals. with bipolar stimulation, an area will be considered eloquent if the patient has movement or has an error of language consistent of at least 3 separate triads. The mapping thresholds is defined as the minimum carrying required to induce a motor response or alteration of language after increasing the stimulation intensity to trigger a response. The post-discharge thresholds. The main advantage is that bipolar stimulation is more focal and can map the language area because the stimulus during 5-7 seconds. The major disadvantage is the risk of seizures. It's about 10-25%. We need to have used a concomitant electrocorticography. The bipolar stimulation can induce a tonic muscle contraction, making it very difficult to measure and compare this response to previous. We need to use, in these cases, the electrocorticography to monitoring the brain activity of patients continuously searching for the presence of this post-discharge activity in the absence of clinical signs of seizures, or such as known as a no-convulsive seizures. This is the captured that data that we shaped during the awake surgery, type of lesion, localization, symptoms, if the patient used or not anti-epileptic drugs before surgery, where are stimulated areas, the stimulated areas, if they have an umbral or post-discharge, milliamperes, umbral mapping discharge, if we have some kind of deficits, localizations, and the proximity of the eloquence area. The language test, we are using a visual naming test, and a word generation test, an understanding sentence test. The test should be performed 3 days before and after surgery within 21 days and 1 year after. And a visual naming test, the test is a robust activator of the essential and non-essential language cortex, especially the broadcast area. The word generation test, we need to use a word generation, is known as a robust activator of the frontal language areas. The answer to name objects presented in auditory form requires the patient to say the name of object that has been described. So it seems that the test also activates language areas in the frontal lobe. The understanding sentence, the patients are presented with 2 identical phrases at all except for 1 word that is replaced by a synonym or a different word. The patient should listen to this pair of sentences and decide which of the 2 has a literal meaning. The test is a pointer activator of the perisylvian cortex. During the wake procedure, just I would say that control of blood pressure is important for with electrolyte level of consciousness. Maintain antiemetics and the prophylactic anticonvulsants, analgesics. If any of the complication infections, seizure, neurological dysfunction, bleeding, cerebral edema, or intracranial pressure increment, we need to do a cranial CT control. Thanks.